Okay. Good afternoon, everyone. Welcome to the February 2024 Optimizing Newborn Nutrition webinar. We're going to start with some brief updates, and then we'll get into our presentation from Dr. Gupta. We have some exciting information to share about the Emory Breastfeeding Conference, so make sure you stay all the way to the end to both log your attendance and to get that update about the conference. So a couple of updates. The MPINC survey, that's CDC's National Survey of Maternity Practices and Infant Nutrition and Care, it launched in January. It measures care practices and policies that impact newborn feeding, feeding education, staff skills, and discharge support. It is done about every 2 years. The CDC invites all hospitals with maternity services in the U.S. and territories to participate. And the way that they conduct the survey is the mother, baby, nurse manager, managers, or the labor and delivery unit managers at your hospital should have received a phone call or an email about the MPINC survey. They try to identify the best person to receive the link for that survey. So if you are not that person that received it, try to identify who at your hospital is the person who received that link. Make sure that the MPINC is completed for your hospital. One of our goals kind of as a state is to see our response rate increase because we can learn a lot from those data, but we can only learn if we have the data. So if you have any questions, it is a CDC survey. So there's that email, mpinc@cdc.gov, and we'll have more information that will come out in the follow-up email that I'll send after the webinar. Another CDC-funded program I wanted to share with you is called CHAMPS National. It is a 3-year CDC-funded program to help hospitals increase their exclusive breastfeeding rates, improve maternity care, and decrease racial disparities. They're enrolling 100 hospitals across the U.S. to get free expert training and support to implement the 10 steps to successful breastfeeding. So they're enrolling hospitals right now. It is free. The hospitals receive free training, receive one-on-one coaching. I'll send more information after the webinar, but that QR code or that cheerequity.org website will get you to more information about CHAMPS along with an expression of interest form if you are interested. So this, again, is separate than GaPQC, separate than optimizing newborn nutrition, but obviously goes hand in hand in a great way to work towards improvement in infant nutrition. And upcoming, we at the annual meeting for GaPQC at the end of April, we will be recognizing hospitals that are on the path to excellence. So there will be the Path to Excellence Award. These are hospital teams that are meeting the milestones to be recognized as Center of Excellence in Optimizing Newborn Nutrition at the end of the initiative. So these are hospitals that have submitted all of their data, that have submitted a SMART aim, that have submitted their driver diagram, that have demonstrated commitment to education by attending the webinars or watching the recordings of the webinars and completing micro lessons. So all hospitals that are in active improvement are eligible to be recognized as being on the path to excellence. You just have to meet those milestones. So if you have any questions about where your hospital team is along that path, please reach out to me and I can give you a status update. And we hope to be able to recognize many hospitals at the annual meeting who are on that path to excellence at this point. We are offering site visits to 4 hospital teams this year. The elements of the site visit are listed there, including a survey of team members, team and leadership meeting, brief interviews of staff and patients, a unit and a hospital tour, and site visit report after the site visit with curated resources. We're hoping to visit 2 NICUs and 2 mother-baby perinatal units this year. If you are interested in hosting a site visit, we'd love to come see you. Please reach out to Claire Eden. Her email address is listed there on the slide, and we will add you to our site visit list. Wanted to let you all know that there are new micro lessons that have been posted. We are up to 20 educational topic micro lessons, and then there are a few QI focused micro lessons. So there are many micro lessons that are up on Georgia Train. This these next two slides, or this slide and the next, list the webinar topics that we've covered and the micro lessons that are associated, kind of linked topic-wise to those webinars. So if you're sitting down with your team and looking at your SMART aim and looking at your driver diagram, you could focus on certain areas. Don't feel overwhelmed by all of the content that we have now. And you can really focus on specific areas that will help you move towards some progress in your SMART aim. Coming soon into micro lessons will be a Georgia WIC breastfeeding services micro lesson, one on oral care with colostrum and oral immunotherapy, and engaging partners and co-parents. Now we want to get into our main part of our webinar, and I want to introduce Dr. Gupta. Shruti Gupta, MD, is the medical director of the Newborn Intensive Care Unit at Yale New Haven Greenwich Hospital. She is also an attending neonatologist at Yale New Haven Children's Hospital and associate professor of pediatrics at Yale University School of Medicine. In addition to being a neonatologist, Dr. Gupta specializes in breastfeeding medicine with a special focus, on preterm mothers and babies. Her goal is to get the family through the difficult first few weeks or months so they can enjoy a normal breastfeeding experience. She's also involved in developing follow-up care programs for families when they transition from the NICU to home. Dr. Gupta is passionate about quality improvement in the NICU. She leads the nutrition QI team for Yale New Haven Health NICU and is a member of numerous other QI committees. Thank you so much for joining us today, Dr. Gupta, and I'll hand it over to you.
Thank you. Are you able to see?
Yes, perfect.
Yep. Okay. All right. Good afternoon, everyone. We are going to be talking about how to support a preterm mother and baby dyad through journey to full direct breastfeeding. Sorry. Okay. So we're just going to briefly review the physiology of lactation, especially in the context of a separated mother and baby in a NICU setting. Not going to go too much in detail there, but just like some quick points to understand the importance of early pumping. We'll go through stages of breastfeeding for preterm infants in terms of readiness and quality, and describe some strategies to support breastfeeding in the NICU and post-discharge, and also appreciate some psychological impacts of breastfeeding, pumping in the NICU, and post-discharge for these parents. I do not have any disclosures. I just want to first start with this basic slide that shows that pretty much right after birth, when the baby's first born, the progesterone levels are extremely high, and soon after birth, progesterone starts to drop down. Prolactin is surging at this time. This is where that first 6 hours, first 3-hour number comes from, because we want to try and put the baby to breast as soon as possible. Obviously, with our preterm infants, that's a lot of times not possible, so we want to try and target this little window and at least start pumping or ideally manual expression at this time. We don't want to wait for a day or later because the prolactin very rapidly starts to drop down. This is a schematic which shows to us that as the baby starts suckling, the mother's hypothalamus stimulates the posterior pituitary to release oxytocin, which is our milk letdown hormone, and the anterior pituitary to release prolactin. When that suckling doesn't happen, none of this will happen. So it's very important that if the baby cannot be sucking, that we at this time start doing some manual expression or pumping if manual expression is not possible. Some recommendations to ease barriers that I can give and has worked in our unit is that if you provide prenatal education, try to include in there that if mom and baby are separated, the best practice would be to start early pumping. We in our centers have now started to include in our prenatal consults the neonatologist, APPs, or fellows, whoever's doing the consult. We include the importance of early pumping in there. In fact, we've sort of templated in our prenatal templates. We've actually put a blurb in there, a standard blurb. We want everybody to be using the same language and really going over the importance of early pumping with mothers. Labor and delivery floor should have pumps and supplies ready for use. You don't want to make this just easy for the parents, but also want to make it easy for on yourself. So if you have to walk all the way to the postpartum unit to grab pumping parts, that's just not going to happen. And so it's really important to do that. We want RNs to be trained in at least basic breastfeeding, so you're not relying on lactation consultants to be setting up the initial pumping. And this should be your norm. So even if the mother of baby delivers middle of the night, is on magnesium, it has postpartum hemorrhage, or whatever the case might be, our goal is to just get these moms pumping as soon as possible. Remember, no preemie comes out of a perfectly planned delivery. It is going to be chaotic for so many reasons. So it's just important that we make this our norm. Usually, mothers are 1-to-1 the first 1.5 to 2 hours post delivery. They are also in a very hyper state at this time when the prolactin is surging. They're very awake right after delivery. They're waiting, they're really waiting for the neonatologist to come back and talk to them about their baby. So this is actually the best time to get a pumping session in, whether it's manual expression or using a pump. But just getting even one pumping session in the first 2 hours of life can actually really increase your success. A lot of people really hone on the 6-hour post delivery. Our goal is really 2 hours, just because by the time the mom reaches the 4 or 5 hour mark, they're usually tired and then they don't want to be pumping. So we really want to try and get this in as soon as possible. Include the birth partner. The dads usually are sitting there not really knowing what else to do. If they can help, take that help from them. We want to try and shift our mindset from we're not overwhelming the mother of the baby by doing this. We're actually helping them, do something for their baby. We also want to set appropriate expectations for output. At this time, we're not looking to produce a lot of milk. We're just looking to stimulate the breast or produce a few drops. So if your facility has small syringes or colostrum containers, those are more helpful than giving moms big bottles at this time. Also, we've instituted antenatal lactation consults for our families that, are on prolonged bed rest. So, at that time, it would be really helpful to make sure that they have an electric pump for home. Just Googling these videos from Dr. Jane Morton can be very helpful, and letting the parents watch these. If your institution doesn't have one, early hand expression for parents to watch in English and Spanish is readily available. And if so if you're not using a pump, this would be the best way to do it. And actually the more recommended way. There's a lot of literature to support this. Early stimulation is critical for long-term success. The most critical determinant of post-discharge breastfeeding is early establishment of robust milk supply. You want to target about 600 mLs per day by 2 weeks, if not more. Delaying initiation can permanently compromise future milk production potential. Pumping, suckling has multi-hormonal effects, which contributes to the recovery of the mother. A mother's emotional recovery is enhanced by her contribution to the recovery of the baby by producing milk for the baby. We have several handouts like that in our facilities just to remind people, how important early pumping is for these families. Next, I just kind of want to focus on a little bit on donor milk. As you all know, in our NICUs, it's pretty much standard of care to use donor breast milk now. If maternal milk is not available, we do focus on early feeding, even if mom's milk is not available. But do the providers always know what the baby is feeding? I can tell you in our facilities, a lot of times when the residents are presenting, they will say mother's milk / donor milk. X mLs every 3 hours or every 2 hours. Nobody really knows what the baby's actually feeding. And this is so important from so many perspectives because donor milk has deficiencies. Donor milk is great for preventing neck and using it as bridge milk, but we now know that babies who stay on exclusive donor milk can have poor growth. Donor milk has less protein, fat, and carbohydrates. It has low sodium, low zinc content, decreased bioactive components like secretory IgA and many other things. So these infants who stay on extended periods of exclusive donor milk, say from like 23 weeks gestation all the way till 34 weeks gestation, they do need extra fortification, maybe liquid protein, sodium supplements. So if the provider doesn't know what the baby's feeding, they're actually can be causing harm to the baby. It is also important to know, what the baby's feeding so that you can help the mother. So if the baby is feeding mostly donor milk, what's happening to the mother? Has somebody talked to her? Maybe we need to assess her pump. I've definitely found moms whose pumps weren't working. You want to go through pumping habits and make sure they're not sleeping through the night completely. One long stretch of 5 hours is something we recommend, but no more than that. You want to increase skin to skin holding. If the baby is extremely sick and for whatever reason cannot be held, then promoting hand hugs is important. Providers also should know what a full milk supply by 2 weeks is. I can tell you I've quizzed many residents on rounds, and even after repeated teaching, people don't remember that. So it's important to teach people what a full milk supply looks like. This is so to help with this, one of our very smart attendings, Dr. Eliza Myers, worked with Epic and MyChart and created this milk clock called Track My Milk. So now the parents are able to enter at each pumping session or just a number for the whole day, the volume that they pumped. And then this number flows into the nursing flow sheet and also flows through a dot phrase into our notes. And this is very helpful for us because it kind of tells us what the mother's milk production might be. Obviously dependent on if mom is entering it or not, but at least it gives us some idea. And as we know from the fitness apps, you're more likely to do something if you are logging it. Next, I'm just going to talk about, how to assess an infant for oral readiness and then, going through stages of breastfeeding. So we at Yale use these feeding readiness assessment tools. So we have a feeding readiness scoring system and a feeding quality scoring system. Different institutions use different scoring systems. Dr. Brown's, the bottle system has their own scoring system. For us, this is built in Epic, so our nurses will score a baby from 1 to 5, and based on that, we decide whether the baby is capable of gavage feeding or PO feeding. And typically, we want the babies to be scoring 4 to 5 in order to attempt PO feeding. And PO in this case includes breastfeeding. So if the baby is having desaturations or really sleepy, then in that case, and I'll talk a little bit more about non-nutritive breastfeeding, but in those cases, we won't be doing meaningful breastfeeding or bottle feeding. We also focus on feeding quality, so it's important to make sure that when the baby latches to the bottle or breast, that the quality of the feed is good before we keep advancing how much PO feeding they're allowed. And our residents or our APPs will present on rounds what the feeding quality score was and feeding readiness score was, and based on that, we look at the overall plan. These script cards are something that I am really passionate about and I find really helpful. So this basically, and I'll go through all these stages, this lists the stages of breastfeeding, and it really puts the care team and the parents on the same page. So we will post these script cards, and depending on what stage the baby is in front of the baby's crib or isolate, and the parents get to read that. It's a nice reminder for the care team what the stage the baby is in, and it also helps parent advocate for themselves. So when they see skin to skin care listed there, and if nobody's offered them skin to skin, they can say that, they can say to the care team, well, can I hold my baby? I see that it's good for my baby. So it just gives us a nice reminder, but also helps parents know what's going on. So we always say breastfeeding pathway starts on day 0. The baby is not quite ready to breastfeed yet, but the parents can hold the baby skin to skin or perform hand hugs if skin to skin is not possible. Mom at this time should be pumping 8 to 10 times a day, including one time middle of the night. The nurses can help moms, hold the baby. Daily assessment of mother's milk supply, either by lactation consultants or nurses, are important at this time. We do pretty strictly follow oral immunotherapy protocol in our units. So every unit has its slightly different protocol. We do give 0.2 mLs every 4 to 6 hours to our babies for the first 7 days at least. And that's usually given as oral care. And it should be mom's milk, not fortified milk or donor milk. This is also a great time to make sure that mom has a home pump, so that if she's getting discharged on day 2, day 3, she's not going home with just a manual pump. Babies usually at this time will be scoring pretty low. They are not quite ready to do any breastfeeding, and they might gestationally also be quite young. Stage 2 or crib card 2 is usually our step 2, which is at this time the babies are a little bit, more mature. They're not like dipping their heart rate or desaturating as much. They are doing well when the mom holds them skin to skin. At this time, we do say that mom should pump and empty out the breast right before the non-nutritive breastfeeding session. And if the baby's getting too sleepy during the session, the idea during this time is just for the baby to for a mom to learn the positions of breastfeeding, and for the baby to just get the idea that while the gavage feed runs, that the baby's mouth is at mom's breast. The baby could be just licking, lapping at the breast, and helping increase mom's production, if nothing else. The goal is not to breastfeed right now. So in the non-nutritive stage, we really do not want to be introducing nipple shields or even talking about nipple shields. And we want to explain the families that the goal is not to latch right now. It's just for the baby and the mom to enjoy this time. If a baby can use a pacifier, baby can do non-nutritive breastfeeding too. That's usually a good way to remember when a baby is ready for non-nutritive breastfeeding. Step 3, these are now older babies who are between 32 to 34 weeks gestation. Their feeding readiness score is somewhere from 4 to 5. They're much more stable. They're not that tachypnic. They're either on a nasal cannula or in room air, or if they're on high humidity nasal cannula, we have specific parameters that we use in our unit to, based on weight, to say if this is CPAP equivalent or not. So if it's less than CPAP equivalent, then we would let them breastfeed. Um, and the baby is usually more active at this time. We teach mom to, watch them for hunger cues. At this time, we still might ask mom to pump after each feeding to increase the supply because the baby may not be transferring just yet. We do not want to be giving any bottles during this time. In our unit, we actually do an exclusive breast practice week for 1 week, and we put an order saying that for 1 week, there's nothing else allowed. And that has actually been very successful, especially in our main Yale unit where, unless you put rules in place, things don't happen. So we just really strictly say protected 1 week. We also tell parents that during this time they should be trying to come at least 2 to 3 times a day so that we can meaningfully breastfeed. At this time, it would be a good idea to assess latch. Ideally, lactation should see the mom and baby at this time. So if a baby needs or a mom needs a nipple shield, this would be a great time. Remember, there are multiple sizes for a nipple shield. We want to make sure that even with a nipple shield, the baby has a good latch. We'd never want to teach baby bad habits. So you want to have a good latch with a nipple shield to maximize the transfer. It's also important that if a baby is being discharged home with a nipple shield, that somebody follows this family through afterwards so that the nipple shield can be weaned off. Step 4 is usually between 33 to 35 weeks gestation, closer to going home. At this time, we could introduce a bottle if that was mom's choice, and the baby is doing well with nutritive breastfeeding, so we start to show them how to bottle feed. I do tell families, if you're going to visit only 2 to 3 times a day, don't get sucked into wanting to learn how to bottle feed. You will eventually learn how to bottle feed, so try to focus on breastfeeding because we can't breastfeed your baby. And we just want to be patient at this time, but we also want to try and do some pre and post breastfeeding way to make sure that we're maximizing any breastfeeding that's occurring. So the key points of our feeding plan that we use at Yale is that we implement an oral feeding assessment for all our high-risk feeders prior to initiation of any oral feeding. Usually speech therapist or OT, lactation consultant in collaboration with the medical nursing teams will be doing this assessment. Stable infants greater than 29 weeks gestation may begin non-nutritive sucking, especially, on a pumped breast would be great, but if mom was not planning on breastfeeding, then we do pacifier dips at this time. Stable infants greater than 33 weeks gestation will usually start to attempt nutritive breastfeeding if they have good readiness cues. We reserve an exclusive period of 1 week for them to breastfeed. Utilization of feeding readiness and feeding quality assessment scores is important. We have an infant-driven feeding order that we place in, and that really brings in all of these orders in for our nurses. And then we advance the feeding plan based on these feeding readiness and quality scores. Um, there's a lot of work being done now on tube-only approach. There was this last Cochrane review from 2016, which basically said that we need more research. We don't have enough evidence right now to say that a tube-only approach to supplement breastfeeding would be a good idea. We don't have enough, enough data to suggest that supplementing breastfeeds by cup increases extent or duration of breastfeeding. I know there are many centers now that are using home monitoring companies to help with tube-only approach, so the babies are getting discharged when they're otherwise ready to go home with a gavage tube, and the mom will breastfeed, and whatever she cannot transfer by breastfeeding will give through a tube. But we still need to see more data on this and more publications on this. And our next stage is discharge planning. Now the baby is getting ready to go home. We highly encourage for parents to spend a night or two in the transition rooms to experience the real deal. Not every hospital has this, but if you do have it, it's really important to try and get them out of the unit and spend time with the baby. At this time, we want to try and at least watch one breastfeeding session 1-to-1 to make sure that the baby transfers the milk properly. Lactation consultant at this time should discuss a full pumping plan for the mother, because the mother may be producing more milk than the baby needs or maybe producing less. So pumping plan is extremely important for them. The physicians should create a realistic discharge plan, and I'll go through that in a little bit more detail. And remember, most preemies will not be 100% nursing at discharge. They really are not that great at it when they go home. And that's why, the post-discharge world or post-discharge nutrition is a very stormy, rocky time for families, because babies are just not 100% when they're going home. Instructions that most babies get when they're going home is breastfeed around the clock every 3 hours. Always offer each breast. Offer bottle after each breastfeeding. Make sure the baby urinates every diaper change. Follow up with your pediatrician. Call MD for, if the baby's not feeling well. These are, I'm sure many of you have seen these, discharge instructions, and these are really full-term discharge instructions and don't really work for preemies. So what can we do to create a good discharge plan? And what are the challenges at discharge? So as you know, in our newborn ICUs, the paradigm has shifted where we give importance to human milk now. Nobody argues that formula is better than human milk, but the support post-discharge is not available. So we do a great job in the NICU, and then we just leave these moms to deal with it on their own. Nutrient needs of a preemie at discharge differ considerably from term infants, yet our instructions are meant for term infants. Preterm infants, both parents and babies, are not really experienced at breastfeeding yet. Sometimes parents will tell you, oh, I tried breastfeeding, once 2 days ago or once a week ago, and they've never tried it again. So they really do need the support. Many of our babies are going home before 2 kilos. So they only have 55 to 60% of body nutrient stores. They do need help. They can very quickly get into metabolic stress if enough energy is not provided. These babies at discharge have some large deficits if they've been in the NICU for a long time. They do need extra nutrients like calcium and phosphorus. And faulty growth patterns with low weight gain in infancy, followed by rapid catch up, can lead to insulin resistance and cardiac diseases. So we want this time to be something that we're watching very closely. So our goals for a good discharge feeding plan would be that there is a good pre-discharge feeding assessment done during the last few days when mom can room in with the baby, ideally. We want to feed as much breast milk as possible so that we can see how the baby does with mom's milk. We want to know what mom really wants to do. I find, and I get carried away too, like I'm really making a full breastfeeding plan for this mother, and then the mom tells me she's going back to work in 2 weeks, and so she's going to be using a bottle. So we want to first ask the mom what she wants and then create a plan based on that. This needs to be an individualized breastfeeding plan, which will look different from what the baby was doing in the NICU, because maybe the mom was just not able to visit too much in the NICU. The plan should correct any nutrient deficits that arose in the NICU. And we need an individualized plan based on labs as well. Whatever plan you create, the baby should ideally grow well on that. It's important to have proportional growth, not just growth in terms of weight. Supplement them with iron and vitamin D as needed, and we want to create an individualized fortification plan. So when you are doing this assessment at the time of discharge, you want to see if is the baby in a suboptimal state or in an optimal state. So is the baby feeding still less than 160 mLs per kg per day, meaning that if the baby was direct breastfeeding, baby may not transfer enough milk. So we need to have that in our plan. Is the mom's supply enough to meet the baby's needs? If it's not enough, we want to create a pumping plan for the mom to make sure that she's putting some extra pumping sessions in while keeping it realistic so that she can actually do it. Is growth less than adequate? Are all the biochemical labs or markers abnormal or normal for the baby? So like I said, the mom might still have to pump after a feed to increase maintained supply. Some moms may need to slow their supply at this time, otherwise they're going to just flood the baby. So we want to create a normal plan to normalize mom's supply. Usually supply will increase once the baby gets home. And some babies still need to do catch-up growth. So we want to try and get them extra nutrition if we can. We want to try and look at growth velocity instead of just the 15 to 20 grams per day. And usually till 36 weeks gestation, we want to use growth velocity. And then we want to give them supplements to correct whatever nutritional needs they might have. Goal is to support mother's breastfeeding plan while optimizing infants' nutrition and growth. This is a little table that we published in Clinics of Perinatology recently, which really talks about the barriers to sustaining breastfeeding for a high-risk infant and what should we do. So if a baby is not receiving enough milk by direct breastfeeding, you want to make sure that we're assessing the latch, evidence of swallowing, optimizing any breastfeeding that's occurring. I always tell preemie parents, breast compressions is your best friend. You really want to do that in order to optimize any breastfeeding. Electronic scales for pre and post breastfeeding are great. I usually do not recommend to send them home with it because we really want to teach parents to start looking at their baby. We don't want to introduce more numbers in their life, which can actually create so much anxiety for them. If infant is not latching, is fussy, again, assess the latch, teach strategies to latch before the infant is crying. Is there any need to change the diaper before we start breastfeeding? Just pick up the baby and start breastfeeding. In the NICU, they're so used to taking the temperature first, changing the diaper first, and then the baby starts crying. Sometimes you may have to start with a bottle feed and then finish at the breast. If the baby's not growing well, what's happening? We want to try and get a detailed feeding history. looking at mom's milk production. If mom is exhausted, and that's what she keeps talking about when you see her, see what kind of support does she have? Did somebody give her a triple feeding plan to go home with where she's breastfeeding, pumping, bottle feeding at each feeding time? This is just not going to be sustainable. So how can you cut that for her? If mom has anxiety, explore reasons for anxiety. Typically, NICU parents have a lot of anxiety, um, and you want to see what you can do. I had some families that just the sound of breast pump gave them anxiety. So once they went home, we had to switch the kind of pump they were using because they just could not take that sound again. Is there any conflicting information that they're receiving? Usually there's a lot of conflicting information these parents are receiving from the pediatrician, from family, from lactation support. So how can we help them to get this all together for them? This is a protocol that was published in ABM, which again sort of goes over all these things. Um, and this is again from ABM, really talking about what is an expected weight gain, length, and head circumference increase for premature babies. We look at alkaline phosphatase for our very premature babies and want to make sure that that is staying low. We look at blood urea nitrogen or your BUN to make sure they're getting enough protein. Look at phosphorus, vitamin D levels, and hemoglobin levels. Just very quickly about a little bit about breast milk fortifier. If there are any neonatologists on the call, we love to fortify breast milk for our babies at discharge. There are different strategies to do that. There are some people that will use 3 feedings of discharge formula and the rest to be mom's milk, or 1 feed of 30-calorie formula. This is definitely not my favorite choice because if a mom has a full milk supply, we don't want to give them formula for a few feeds, and also creates a competition between formula and breastfeeding where mom starts to think that formula is better for the baby. Adding powdered preterm discharge formula to express milk feedings to enrich it to 22 calories, 24 calories. This is something we commonly do in order to give them more calories, but also give them more calcium and phosphorus. The third option is usually less popular, where babies go home with a supplemental nursing feeder, and some feeds are supplemented using formula. And as you can see in this slide, you can see with all these options, different calories, protein, calcium, and phosphorus content, but pretty much all the options give about the same calories. So definitely not true that sending them home with, half feedings of formula would be beneficial, unless mom's milk supply was at 50%. And then in those cases, that would be okay. Having said that, neonatologists like me, we all love sending them home with fortification. At the same time, the data doesn't really show that that's a good option. This was a Cochrane review that looked at several studies. These did not provide evidence that multi-nutrient fortification of breast milk for 3 to 4 months after hospital discharge affected rates of growth in infancy. One trial even looked at 18 months corrected age, and they did not find any statistically significant effects on neurodevelopmental outcomes. So are we just making ourselves feel better by sending them home with these fortified feeds? We don't know. We do need more research on that. Most of the work that we look at actually comes from formulas, so comparing a preterm formula to standard formula, but we don't know if a baby is really breastfeeding well, should they be fortified or not. And the last 10 minutes, I just kind of want to focus on my NICU to home program, which I'm really, really passionate about and strongly believe in. Our babies go from like this full 24/7 monitoring to a confused parent, and sometimes even confused care providers. So these families definitely need help transitioning from numbers to really cues, and learning how to take care of these babies once they leave from the NICU. So we have developed this NICU to home program. There's different versions of these kind of programs, at many centers. But the bottom line is that these families do need help. Transition to home can take 4 to 6 weeks. During these visits, we observe a feeding session post-discharge and create individualized plans based on that. We do pre and post feeding, post breastfeeding weights. We also do postpartum depression screening for actually both mother and father. Any labs that need to be drawn can be done right in the program, so the parents don't have to bring this preemie baby that they're terrified to go anywhere with to a lab. We would assess for frenotomy if needed. Weaning from nipple shield is part of this program. Counseling and ensuring all follow-up appointments are made correctly. There's so many times we make all these appointments for these families, but once they go home, something happens and, they don't show up for appointments and things like that. So it's important to go over that with them. We work with the pediatrician, so making sure that their pediatrician appointments and our appointments are sort of spread out. And then we hand them over the really high-risk babies to our high-risk developmental follow-up program after the 3 visits in the NICU to home program. This was a pilot that we did in our program where we compared 41 babies that didn't come to the program to 58 babies that came to the program. And our results were great. We found that babies who came to the program on an average breastfed 6.6 months compared to 2.69 months for the ones that didn't come to the program, which essentially means that shortly after leaving the NICU, they stopped breastfeeding. No surprise to us. Participants in the program were 3.3 times more likely to breastfeed for at least 6 months compared to those who did not attend the program. We had huge satisfaction from this program. In fact, even our inpatient breast gaining scores increased because the families really felt that we cared for them even after they went home. The principles we used were mother's feeding goals were clearly discussed, home feeding log was reviewed, infant's ability to transfer milk and stay satisfied for 2 to 3 hours was seen. We observed the feed. We tried to make sure that the baby was gaining weight and growing. Appropriate hydration status, making sure there was good urine output. This is, of course, less of a concern in an older preemie, but the new ones, this was a criteria as well. We helped mom navigate her milk supply, so a clear pumping plan was made for her. And we provided support to parents and the pediatrician as well. Some parents honestly came to us for the second, third visit only because they wanted to talk to us, not so much for breastfeeding. We also created a breastfeeding quality assessments scale, which is similar to like the quality score we discussed before, but this was really meant for post-discharge. And we scored them from 1 to 5. And based on this, we kind of decided how many breastfeeds should be added. So a baby that scores 5 is somebody that's really able to breastfeed very well ad lib and does not require supplementation. And you can reliably, do cue-based feeding. Somebody that scores 1 is really not in a stage right now to be really meaningfully breastfeeding. Most babies will go home between stage 3 to stage 4. So, we found through this program that you really have to have a meticulous approach in increasing breastfeeding slowly to have successful breastfeeding results. If you try to jump too fast or scale back too much, you lose the balance, and then moms very quickly pivot towards giving only bottles. There are many scores available like this that I've come across, but some of them, some places send parents home with these scores. I strongly believe that the parents shouldn't be going home with these scores. They should not be the ones doing this scoring system because we, again, don't want to put more numbers in their head. This is something that we want to use for our providers to make sure that everybody's on the same page. And then based on this scoring and how the baby was doing, we sort of had like a roadmap. So we looked at what was the weight gain between visits. We looked at a breastfeeding log, breastfeeding scores that our lactation consultants did. Our providers also looked at the nutritional assessment, so looking at labs and as such. our NICU to home team talked to parents, and we really spent time seeing how they were doing at home. And then we created a feeding plan for them for 1 week. And then we saw them within a week again. And usually after 2 visits that were a week apart, we had very good success. And then we saw them usually by their due date to make sure that we weaned them off nipple shield, or, if they needed anything else, we took care of the labs and as such. And typically, you would see if you didn't have a NICU to home kind of program, the only thing that sometimes gets looked at is weight gain. And the whole plan is based on just that first step, whereas, as you can see, there are many steps in this ladder. There is a high incidence of postpartum depression in preemie parents, seen delayed in fathers. So it's really, really important to use this opportunity and talk about that. So again, just coming back to instructions most babies get, which I said don't work for preemies. Compared to that, sending them with instructions like breastfeed 4 to 5 times a day, bottle feed 3 to 4 times a day, use frequent hand massaging and breast compressions while nursing. Empty one breast completely, baby might fall asleep at this point. Give them strategies to wake the baby up before going to the other breast. Talk to them about pumping plan. To not say breastfeed every other time or bottle feed every other time. Give them some flexibility in there. Don't limit the time to 20 minutes. Every parent of a newborn knows that this whole deal takes over an hour. Revisit the plan in 3 to 7 days based on the weight and every few weeks, and look at growth and labs as well. So just in summary, preterm infants are at risk for growth failure in the immediate post-discharge periods. Neonatologists should list growth goals and recommended labs clearly for pediatrician at discharge. Some breastfeeding support must be provided after discharge, ideally multidisciplinary. Close monitoring of growth and biochemical parameters using growth curves and labs should be assessed. Emphasis should be on proportional growth. Develop proactive rather than reactive approaches. Each preemie and its family is unique, so it's important to have a tailored approach. Fortify breast milk when it's possible till consistent growth. And if you are weaning the human milk fortifier or whatever fortifier the baby was on, make sure the right supplements are being added. And clear plans for supplements should be made. And just I want to end with saying at this time, I might have confused a lot of people, and you might be wondering why deal with all of this and why not just use formula. There's a lot of data to suggest that formula is not better than breast milk. So I just want to, leave this as a reminder that we have plenty of data to show that when you're not getting breastfed, a lot of things are affected. Your mental scores are much, going to be much lower than if you were breastfed past 2 months. So just important to remember that. That's it. If anyone has any questions, I'm happy to take them. And you can always email me if you needed more information on anything that I presented. Thank you.
Where, if it's still
Somebody needs to mute, I think, so we can see if there's any questions.
Do you have one question that was sent, Dr. Gupta? Thank you so much. That was an excellent presentation. Do you have any advice for working with team members to correct the belief that giving a baby formula may get them home faster in the NICU, from the NICU?
Yep. I mean, I think the last 2 slides that I presented were for that reason. And secondly, I had a slide in there which showed doing the 3 feeds of formula doesn't really get as much extra fortification and, extra protein in there or extra calories in there. So we really, try to explain to them that formula does not have more calories. In fact, the babies usually throw up formula more, so they're more likely to go home, faster if they were breastfeeding. And using breastfeeding scales in the NICU can be really helpful because, as you know, like neonatologists, neonatal nurses, we all love numbers. So when we can see a number, we feel good about it. So we've really, started using that as a tool. And especially in our level 4 NICU, we found that people just find that so useful. And if they can chart that the baby fed 30 mLs and they're fine, then they don't care.
Great, thank you. other questions either in the chat or you can come off mute and just ask.
While we're waiting to see if anyone has any questions, I have a question for our audience. Do you think it would be helpful, and y'all can jump in the chat, to have a micro lesson on ACPC weights or pre and post weights in the NICU? Is that something you're all already doing and feel comfortable with, or do we need further instruction there?
Well, folks, think about that, Claire. We have a couple of questions coming in the chat. The first one's, what's your lactation staffing for your NICU?
Yeah, so that's always an interesting question. So we have 5 Yale NICUs. One is our main flagship NICU. The others are our level 3 NICUs. Different staffing in all of them. I will say my Greenwich Hospital NICU does not have a NICU dedicated lactation consultant. So a lot of it falls on the neonatologist, who's IBCLC, i.e. me, and also some of our nurses who are really into breastfeeding. Same thing at our Bridgeport NICU. We do have champions, amongst our neonatologist staff, which has been very helpful. Of course, at our level 4 main Yale NICU campus, we have lactation consultants, but again, you can get a lactation consultant appointment in like a week's time sometimes, even when you're inpatient, because we just don't have enough people. So it's the nurses who are really taking it mostly on themselves to do it.
And then another one, how do you adapt the milestones to the level 4 NICU patients, if at all? Do you have a 1-week breastfeeding protection plan for the level 4 too?
Yeah, actually, that's where we started at first. So we really, because in our level 3 NICUs, we had the ability to really tailor it. So we could say, okay, maybe 5 days works for this baby or longer works for this family. But we didn't have that ability in our level 4 NICU. We had to come up with a strict rule, otherwise it wouldn't be followed. So we started with 1 week protected week there. And I saw a question there where somebody said, would that keep the baby longer in the NICU? And actually, we have recently reviewed our data, and that's not true. That actually helps them get home almost the same time, if not sooner. Yeah, and one of the reasons for that is that that's the time when when people start calling out reflux on a lot of these preemies. And in my opinion, the reason for that is that they're just getting bottle fed so fast. There's no pace feeding that's happening. And, so the milk goes in, it's going to come out, and then we start doing all this workup. So they end up actually staying longer because they're going to be on an apnea watch or something like that, versus like the slow breastfeeding week that really helps them mature a little bit. And then we start introducing a bottle.
Any final questions for Dr. Gupta? All right, thank you again so much, Dr. Gupta. That was a fantastic presentation. A lot of great information for our teams. We appreciate it.
Thank you so much for having me.
And then I just have a couple more slides for everyone before we wrap up for the afternoon. Starting with just a couple important dates. The Emory Conference on Breastfeeding is April 11th and 12th, with a pre-conference workshop on April 10th, which is a breastfeeding fundamentals for healthcare providers. There'll be more information on this in a second. The GaPQC annual meeting is April 25th and 26th at the Emory Conference Center. And we'll have more information about registration to come, but just make sure that you have saved those dates. Your February audit will come out on Monday, on the 19th, so this coming Monday. And then our March webinar is scheduled for March 12th. So as I mentioned, the Emory Conference on Breastfeeding is coming up in April. New this year is the pre-conference workshop on April 10th, which is at Breastfeeding Fundamentals for Healthcare Providers. And we are excited this year to be able to offer GaPQC scholarships to the conference. So scholarships will be limited to 2 per participating hospital team and are available on a first come, first served basis. So within your team, please discuss who would most benefit from the scholarship, with priority given to providers, nurse leaders, team members who did not attend last year, and those who have been actively participating in the Optimizing Newborn Nutrition Initiative. Scholarship for both the pre-conference workshop and the main conference, which in person, are available, and you can register for one or both. The scholarships are offered in the form of a 75% off registration discount on the early bird pricing. There is the process will be, you'll submit a short form, so fill out some information and submit that, and then you'll be contacted with the code and instructions for registering. This will help us make sure that there's coordination among hospital teams and making sure that 2 people are attending, and that it is not concentrated just to a specific hospital. We want to be able to have this opportunity extend across hospital teams. The pre-conference course, Breastfeeding Fundamentals for the Healthcare Provider, is offered in partnership with the EPIC Breastfeeding Program. It's not intended for practicing lactation consultants, counselors, specialists, or educators. There's 6 hours of continuing education for physicians and nurses that will be offered with that pre-conference course. And then there's 12.5 hours of continuing ed for physicians, nurses, lactation consultants, and dietitians for the main conference. So there's a distinction there on the target audiences. I'll come back to this slide. I want to make sure we put up our attendance slide. So make sure that you log your attendance for this month's webinar using that code, and then I can go back to that slide on the conference information if there's any questions, and we're happy to answer those now, or you can stick around once we are done, which we are done. Really. So thank you all for joining us this month. Like I said, if you want to hang around, if you need to ask any questions, please do. Otherwise, we will see you all in March. Thanks so much.